Hello, and thanks for joining us today. I'm Courtney Galster, and I'm joined by Mike Den Eynde, the Managing Director of Deloitte, Mike Selvage, a Senior Manager with Deloitte, and Michael Lunzer, the CEO of Itiliti Health. Welcome to all three of you.
Thanks. Morning.
We are going to talk a little bit about improving prior auth processes and the CMS final rule. But before we dive in, why don't we kick off with some introductions? So Mike, would you like to go first?
Hi, Mike Den Eynde, Managing Director, been with Deloitte for over 25 years, and the majority of that spent in kind of the care management population health space. So we help a range of health plans with kind of their overall strategy, operational redesign, to vendor selection implementations across technology and services. And so we've been watching the CMS rule closely. We think it's really going to transform for a lot of health plans and providers. So we look forward to the conversation.
Wonderful. And Mike Selvage, would you like to give us an introduction?
Sure. Hi, everyone. My name is Mike Selvage. There's going to be a lot of mics on the phone call today. I'm a senior manager in Deloitte's healthcare ops and tech transformation practice. I've been with Deloitte for 14 years now, focused on value-based care and population health. I'm based in our Austin, Texas office, and along with Mike here, I help lead our consulting offerings related to care and utilization management, and really excited and looking forward to talking with all of you about this prior auth rule that we, as Mike said, we believe is going to be very impactful. So thank you very much.
Michael?
Thank you, Courtney. I'm Michael Lunzer, CEO and founder of Itiliti Health. Really excited to talk with you today about how prior authorization solutions can impact the payer and provider marketplace.
Awesome. Well, let's talk a little bit more about what that final rule looks like and how it impacts different organizations in the healthcare space. Deloitte team, would you like to kick us off?
Sure. So hi again, everyone. I'm going to start us off by spending a few minutes introducing the CMS Interoperability and Prior Authorization Final Rule and describing a few of the implications for health plans before handing it off to my colleague, Mike Den Eynde, to talk in more detail about what actions payer organizations should take. So at the highest level, the final rule is going to subject health plan organizations to new requirements focused on improving the prior authorization process. And the goal is really to reduce some of the decisioning timeframes and create a more transparent process for members and providers. We believe these requirements are going to have considerable implications across the industry that are ultimately going to drive payer organizations to rethink the current approach from a clinical perspective, operational, provider relations, and even a technology perspective. In some of the discussions we've been having with health plan leaders, it's clear to us that 2024 is going to be a challenging year from a capital perspective. So we're recommending that organizations start with clinical strategy and operational oriented actions, or focus on technologies that can not only meet the requirements of the rule, but also provide a more immediate path to value realization. So just to spend a minute on what's included in the final rule, for those of you who may be new to it, there are really 5 elements split across 2 effective dates. In January of 2026, there are sort of 2 key requirements. First is that the turnaround time for standard authorizations is going to be reduced from 14 days to 7. And the second is that health plans are going to be required to publicly report what is currently on their respective prior auth lists and certain prior authorization outcome metrics, things like denial rates, appeal and overturn rates, and average turnaround times. Then in January of 27, this is when the interoperability and prior auth API requirements go into effect. That includes building a prior authorization API that can tell providers for a specific member and a specific service if an auth is required and what documentation is required. It's also going to require enabling the PA submission and to share the decision outcome, including the rationale in the case of a denial. For providers, they're going to have a new electronic prior auth metric under the MIPS payment system as a means of incenting greater EPA adoption. And then there's also going to be new interoperability requirements focused on enabling transmission of certain member data between payers and in-network providers, as well as payer-to-patient API that's focused on communicating prior auth decisions. I just want to note real quick that the rule does not apply to pharmacy prior auths, so this one only focuses on medical, and it really focuses on products under the jurisdiction of CMS, so Medicare Advantage plans, managed Medicaid, Medicaid fee-for-service, as well as qualified health plans on federally funded exchanges. So no commercial initially, but we believe that if the process is adopted for other lines of business, we would expect most organizations will include commercial as well. Okay, so now that we've talked a little bit about what's included in the rule, let's talk about what these requirements mean for health plans. So clearly, the shortening of turnaround times will have an impact on operations for some organizations. While we believe many, if not most, health plans complete standard auths in less than 7 days on average today, the rule requires all cases to be completed in less than 7 days. And in today's economic climate, we don't anticipate health plans being able to staff their way out of this challenge. So what's more likely is solving through automation, which we're going to talk a little bit more about later in the presentation. There's also potential for more denial of cases, particularly when there is missing clinical documentation. We think that in turn may have downstream impacts on appeal volumes and overturn rates when the appropriate clinicals are ultimately submitted. The transparency aspect of this rule, we believe, will actually be the most transformative of the new requirements. Variation in prior authorization approach internally across lines of business or in comparison with industry standard practice, we believe will now be under the microscope with the public reporting requirement. We've seen in recent months both increased scrutiny of denial rates, as was called out in the 2023 OIG report, as well as very high approval rates, as we're seeing with some of these gold carding legislation in certain states. So as I mentioned before, this may call for transformation of the strategy for many organizations. Last is the technology implication. For many organizations, just the development of the prior auth API presents a challenge in trying to integrate member eligibility, provider PAR status, and codified prior authorization rules. But just as important is the ability to drive provider network adoption of the API developed, and we'll spend a bit more time on that topic later as well. So what action should a health plan take to not just prepare for the requirements of the rule, but the broader industry shift that we think is going to occur around We would sort of suggest there are 4 domains to consider that I'm just going to kind of introduce, and then I'll hand it off to Mike to talk through in more detail. First is evaluating your organization's prior authorization list, your appropriate use criteria, what's on your medical policies, and evaluating that against some of your prior auth outcomes to really confirm there is sufficient clinical and financial detail that kind of justifies what you're doing as part of your strategy today. The second is transforming your clinical operations through greater automation of the end-to-end process. The third is determining how to best engage your providers in the discussion around transformation. And then last is assessing your organization's broader ecosystem of technologies to determine what investments still need to be made. But with that, I'm going to pass it off to my colleague, Mike, to talk through health plan actions in a little bit more detail. So I'll hand it off to you, Mike.
Thanks a lot, Mike. Appreciate it very much. So going back to those 4 topics, the first one up is rethinking from kind of start to finish, right? There's just a lot of outside pressure to change utilization management from all fronts, right? It goes back to some of the reports generated last year where the Kaiser Family Foundation found a huge variation in the amount of prior auth requests by health plan for Medicare Advantage population that ranged from 3 per person per year down to just 0.8 per person to year, right? There was an OIG report looking at Medicaid that found significantly higher denial rates and very low overturn rates in Medicaid populations, and their kind of suggestion that most states do more rigorous oversight of utilization management. And because of these things, there's legislation in many states, right, trying to further push turnaround times to what can be authorized even. So there's a lot of pressure. So health plans, like even beyond this CMS rule, really have to kind of make sure that whatever they're doing in this area is truly thoughtful, right, and is well conceived. Because if you don't, it will all end up on the cover of the Wall Street Journal in a couple of years, right? I think it's going to be that watched closely. The reporting that Mike talked about that we think is so transformational, right, will force every health plan to kind of put out their approval rates, denial rates for every kind of procedure down to the CPT level. And so you'll get just as much grief for something with a 99-cent approval rate as you will something with a 50% denial rate. So you have to really know why you're doing what you're doing. So we would suggest there's kind of a couple things to take into account. In the top left of this page, we're talking a lot about you got to do that deep ROI analysis. You need to understand for every kind of CPT on the list, the volumes, right, the approval rates, and its impact on other things. If you have a lot of value-based care going on, like how many of these really should be still in place in those kind of components. We think we added here site of care. We think that that is a huge benefit for everybody if we get the patient to the right site of care. And there's been some leading practices of nudging through the prior auth process to the right side of care. We would suggest people think about that. But when you finish that analysis, you'll be able to see by appropriate standards, where are you strong and where are you weak? And you may also therefore have to figure out if things are very high, right, and everyone's appropriately using it, then maybe true prior auth isn't the answer for a category. And then you should look at other kind of components. On the top right, we're talking a bit more about the idea of peer-to-peer review, right? There's some categories such as oncology, cardiology, where the answer is not to deny care. It's really to make sure it's the right care that's kind of taking place. So we found some organizations are having success with, instead of going to a non-denial approach to those categories and kind of pushing for communications and peer-to-peer reviews between the oncologist and cardiologist with experts from the health plan or from their vendor to talk about what they think the right guidelines are and why they should potentially think about changing the course of care for that individual. That's something where health plans could create themselves, but vendors, because they could kind of hire one or two experts and leverage that across many health plans, may be an answer and a kind of a key piece that they may kind of look at. When we kind of get comprehensive, we also think we have to kind of include more around care coordination kind of efforts. To date, is sometimes used as a trigger for care coordination, but with the cost of medical injectables and the prevalence of SUH issues we see with individuals of transportation and financial need, the idea of following up prior auth with making sure that the drug is or kind of procedure service is being used well could make a lot of sense and ensure that there's not duplicate use or wasted usage of the components. And then finally, as you get through that, for the components that are still left that really should be on a PA list, it's thinking through the technologies, right? Like, how are you going to get this all done? And is there a couple of categories where instead of being on the prior auth side, that it should maybe be at the post-claim prepayment level, that you kind of do some review for inappropriate use instead of appropriate, and therefore kind of stop some of the pain, but you have to publish those standards. So you can see, like, there's a lot to do in this component. There's a lot to think about, and therefore we're suggesting health plans do that now. So, but if you get through that component then, right, and as the rule kind of says, we're trying to get down to like a 7-day maximum kind of for approval. We talked to most plans. There are a lot of them average 10 days. There's not too many who average the full 14, but we don't know anybody who's at a 7-day max, right? And so to hit it with staffing seems ill-advised at this point for any health plan, right? Everyone's struggling from kind of a cost standpoint. So we really think automation is the answer. And there's really 3 categories of automation that could kind of help you. First is on the intake side, right? If life would be so much better for everybody if we could please just stop the fax and phone calls, right? Like, we would all be so much happier. That's the nirvana. The rule is actually kind of shooting for it to a certain extent. But you can see if it's in place, you could get those coverage requirement discoveries in. You could kind of tell whether an auth is needed easily. And Itiliti has found it, others have found it, that if you can make it easy for the provider to know what needs an auth or not, you'll see 30% reductions in the number of authorizations, right? Which is a huge savings on both sides. But the intake could also help, therefore, make sure that the provider knows kind of the documentation and the data that you're after. The FHIR standards can even make those submissions in data element format versus the medical record. And that too could hugely increase the efficiency of the whole process and ensure that there's not this back and forth around missing data. That's the pain of the whole process right now. So we think there's huge kind of savings just in the intake piece alone. When you get to the auto approval, the idea would be if we have data elements coming in instead of medical records, right? There's a certain number of auths that could be approved just by simple rules based on some of the data that's in kind of the banner of a 278. But as we get more advanced with a bit of AI support, right, they could actually look at the data elements, make sure they're all within thresholds, right, and make approvals before it gets to the nurse. Of course, anything that we still think has potential for denial still has to go to the nurse and then to the physician. But we think that could be a huge drop in the volume of staff needed for these kind of components. And for the last group, there definitely will be some cases, some categories where medical records, will still be needed. And in those cases, we're seeing some great advances in using natural language processing, large language models to kind of take a medical record, read it, and extract from it or point out the key data that's needed for an approval, and then put that kind of summarized information in front of the nurse and allow them to make a decision in half the time that they do now. So if you could get all of this working well, we do believe there's up to a 75% reduction in the admin in providing utilization management for a health plan. Now, but to get there, like all this has to be there and it all has to be executed and it all has to be done with the collaboration of providers, as we're about to talk about. So that's a lot of ifs on the backside, but the value is there. So the provider side of things around this, right, is that the rule itself does not push the provider too hard to go into this world, right? The MIPS measure helps a bit, but it is an attestation-based method, right? So if you are submitting one auth electronically, you kind of check that box and you get the value as a provider, right? It's not about the percentage that are going through that. And again, like the MIPS payment only impacts the rate that you get for fee-for-service physician services, right? So that's not all smaller practices. It's a small part, a smaller and smaller part for health systems as well. So that in itself isn't going to change the world, but the Deloitte's revenue cycle practice that works with a lot of providers are hearing a lot that the biggest opportunity most health systems believe is around reducing denials around utilization management is probably one of their biggest opportunities. So taking the rule to its max, we believe if the provider submitted electronically, they could see up to a 40 to 50% drop in their admin spend on submission of these components, right? They could easily see margin improvement of reductions of 5 to 10% or more in their denial rates with health plans because the right data is being submitted. And they could see a reduction in their admin cost as well, right? With their average cost being at least $6.50 per transaction that they submit. And then finally, for both sides, the patient experience could be dramatically improved if we had reduced turnaround times and less surprises kind of down the road. So there are advantages for both sides, but for the providers, it's not smacking them in the face in a lot of cases. So it's going to take a bit more work to get them to kind of buy into this and support this. But we believe it's essential that it's done, right? Because if the health plan creates this technology and it's really not being used by the providers, no one's really benefiting, right? So we would suggest as part of your kind of build of this, that you have to kind of engage your provider network sooner than later and talk about a couple things. Like one is establish what's the right approach for this market, right? Like what technologies make sense. If you're very big into X12 and have portals and kind of intermediaries that are well in place, can you leverage some of that? Or, do we all agree that fire is the right place to start? But if there's some agreement to that, then the investments kind of come at a rate that's acceptable to all. We think most health plans will have to consider some monetary incentives beyond the MIPS measure, that they may want to talk about building some of this into their VBC contracts, right? Or even kind of some type of rebate or subsidy at the end of the year for the number of electronic submissions. It would be worth the savings that you would get to kind of think about some of those components. But beyond that, there's also just being transparent, right? This is where Itiliti helps really, is being transparent about the criteria, making sure exactly they know what you need and when you kind of need it for the pieces of it. Gamification may be a little strong, but we really believe what's been kind of lacking in the industry is true transparency on utilization, right? That if you were to make benchmark available of the utilization of Dr. A versus Dr. B, C, and D, and they seeing those differences, we find that can make a difference in some of these components. So using some of that to explain why you still need prior auth in place for some of these categories that are difficult for them, I think is the only way to get both sides to agree to do something kind of different. And in a couple of cases, and the last one here, what we see is some health plans that are also health systems, when they're both together, have created some technologies already to support interoperability and the passing back of prior auths. And once they built it for themselves, they've made that available to some of the other providers in their marketplace to reduce the cost of implementation for the providers, because that will be the impediment. If the providers have to spend a lot to do this, it'll be a slower trek to get them to support it. But it's worth, therefore, subsidizing in some way to get there for the benefits for all. So then we get to the last one of the technology, right? The part of the rule to us that we feel is the least defined, right, where there's a bit more open, is around like how much you're using X12 versus fire right off the bat. The one change from the earlier version of the rule was they kind of opened the door to say X12 may be enough to get started with. But if you kind of look at it, like while they say that, like to meet all the components of the rule, there's certain pieces of it that just aren't included in X12. Like you can't do the kind of the availability of the exact data per CPT that's needed. You can't do that in an X12 transaction, and you can't meet like the API requirements in an X12 transaction. You will need kind of the fire components to it. And in general, while the fire may be a bit easier at first, the X12 may be easier at first. The fire transaction is much more robust, right? And provides a lot more data and allows us to get to the full benefit possible for both sides. So I think we're suggesting that while X12 may be an opening point in some markets, we would suggest that all health plans kind of work towards fire-based suite of solutions for the 2027 deadline, so that they're in place on all components. But that can change by marketplace. And so then, when it comes to the technology itself, this is a page that we've kind of talked with a lot of health plans, health systems, even vendors about, to kind of describe what we think is kind of needed, right? And so the dark blue boxes on the outside of both sides is what kind of exists now, right? Most providers have the EHR in place, and most health plans have a care management platform and kind of claims platform in place. But we don't think that's close to enough to meet kind of the idea of this rule. We think that health systems are going to need something close to this intelligence module that we're talking about that would sit outside of the EHR, right? That when an order is put into the EHR, would recognize that they have to check if an auth is needed. And if an auth is needed, would help kind of populate the right template with exactly the right data and ship that off to the health plan, and also be able to track the status of that prior auth, like when it's approved, denied, or while it's still pending. And that's where the provider piece stops. And the rest of this is kind of for health plans to a large extent, right? Most health plans have a fire layer already in place, but obviously this is going to expand that directly. Most have an EDI X12 layer in place, but they'd have to make sure it can meet all the requirements that we're talking about here. But behind those is this whole new level of capabilities that we don't think exists in any care management system so far. That's really that kind of set of rules, AI thinking that can automate the approval of components, right? It will take AI and rules-based to kind of know which, as an office kind of comes in and looks at the data, can we auto-approve it, or where are we shipping this to? Does this have to go to one of our vendors? And to do that well, the data behind it, around your medical policies, around the eligibility of your members, and the network status in every network for all your providers is needed to support that. And you're going to need clinical content to support some of that as well. And then finally, if you're getting to the medical record component, that last green box around PA decision intelligence is the idea of if it has to go still to a nurse in the end, that you may want to have that intelligence layer to kind of support the nurse in showing them exactly what they're looking at. They expedite them finding the right data in the medical record to help them make a decision. While the final record, of every auth should end up in the care management system and passed on to the claim system, we don't think you're going to be able to do all these components just with the care management systems as they exist today. So you need to talk to your vendors about what they have in place and what will they have in place, more importantly, by 2026. So you'll be ready for 27. And is there other vendors you need to supplement, therefore, to meet both the short-term and long-term wants of this kind of metric? So that is a lot. I'm sure I've slightly overwhelmed you at this point, and I apologize. But we think you don't have to do it all at once, is what it comes down to, right? We know that what I just ended with all that technology will take a while, and no one probably has a lot of money budgeted for those components in 2024, and we think that's fine. That it makes sense, though, in 2024 to start with some of those first components of analysis and understanding your medical policies and what's really the right approach for you in your marketplace around automation, and even which policy should you kind of eliminate altogether and not have any prior auth. Doing some of that now, and therefore figuring out your digital approach to those components, and even starting some conversations with your provider partners around this, all makes sense to start now, so that by the end of this year, you have a plan in place, and you even have an idea of your budget for technologies, so that you can kind of begin the technology work heavily in 2025 and 26 to be kind of ready. But I would say to you that a no regrets piece of technology to put in place early, if you don't have something in place to support it, is Itiliti's solution to help you with the prior auth listing of components, to be able to kind of create the digital versions of all your medical policies now and putting them out on the portal for your members to see now, even next month, well in advance of any technology need, will start to get you some of that 30% benefit of providers using it and reducing the payload, the workload for everybody now. So we think there's ways of trying to pay for some of these changes as you go with the Itiliti solution. So that's the core of our presentation. We at Deloitte would be happy to talk to you more about these components and have ways of doing very quick assessments or longer term assessments to help you with those components and thinking through all of this if you would like down the road.
I think that gave a lot of clarity on the next steps that are required both for providers and payers in this new rule. Before we dive into Michael's part of the presentation, I just wanted to note that we'll add everyone's contact information at the end of this session, and we'll also include the presentation docs. We'll send those out as a separate email post-event if you are looking to review them once we conclude. But before we get into all of that, let's bring on Michael Lunzer to talk a little bit more about how you can gain compliance with CMS prior authorization API requirements.
Thank you, Courtney. And thank you, Mike and Mike. That's great detail and background on the CMS requirements, and a perfect segue to what I wanted to talk about is really to go a little bit deeper on the API requirements specifically, and kind of some of the steps that a health plan can take in a phased approach to ultimately gain compliance. So before I do that, I just wanted to spend one minute talking about the impact of all of this. Over the last 4 years with COVID and other challenges, we've seen a tremendous amount of pain that the providers are faced with. And, there's been many surveys and details published about the impact of prior authorizations on providers. And not to mention, we've also seen providers that are dropping certain Medicare Advantage plans because of these kinds of administrative burdens. And what's really exciting is that the prior auth work that's being done and as part of the CMS regulation should have a major impact on this big challenge. When we think about it, eligibility and claims are huge impact on the market on healthcare, but they're highly automated and highly electronic. Prior authorizations, on the other hand, are extremely manual. And so this is a big opportunity for all of us to make change that's very impactful. So as we talk about the API, I just wanted to kind of outline the key steps of a prior authorization so that we can be very specific about where these different API elements are effective. So typically, a doctor writes an order. Once they've written an order, there's an administrator at the provider organization that goes in to schedule and verify eligibility, as well as look at prior authorization requirements. Typically, this person is titled as a referral coordinator or some other title that's really focused on this administrative process of scheduling and verifying requirements. As part of their role, they go out and look to see, is a prior authorization required? And typically that involves going out to a health plan's website, looking at their prior authorization list, which is usually in a spreadsheet. And oftentimes they'll go out and look at the actual medical policy or guideline that applies to a particular requirement. And in that process, they're looking to see what are the rules for this particular patient, for this particular procedure on this date of service. And one of the challenges, of course, is that health plans have many different variations of these rules, depending on which plan or which contract that member belongs to. So this becomes a real challenge for providers to dig through these reams of content. Ultimately, the often response by the provider administrator is either to pick up the phone and call the health plan to ask, is a prior auth required for this patient? And that, of course, can be a 10 to 15-minute telephone call. And oftentimes the health plan resources using the same crummy tools that providers are given. Sometimes they give the wrong answer. So that's not a great solution. So sometimes providers just default to submitting a prior authorization. And that's not a very efficient method either. So that's where this challenge of how do we effectively answer this question of, is an auth required and what are the clinical requirements of that auth? That's an important step in the process. The next step for that provider admin is to document and submit the prior auth. And then, of course, the payer needs a method to decide if that prior auth should be approved or not, and approve or deny it. So that's the high level of what happens today. And so what we're going to talk about is, how is this being transformed through the new CMS requirements? So first of all, just to recap, the CMS interoperability requirements were finalized in January. Compliance for this component that we're talking about is required by January of 2027. So in other words, payers need to build or implement a prior auth API by the end of 2026. And as Mike alluded to, the common approach for this solution is a product or a capability that was devised by the Da Vinci project within the HL7 work groups. And they defined a prior auth requirements, documentation, and decision API that some have called PAR-D. And ultimately, by the end of 2026, all payers need to have an API in place. So that means if you're working towards this, it's a really big ask and not a small task. So it needs to be done in the next 3 years. So what does this really mean? Essentially, this requirement breaks down the prior auth transactions into 3 categories. The first is called the coverage requirement discovery, or CRD, and that is the transaction that answers the question for the provider, is this prior auth, does this procedure require a prior auth for this patient? The next transaction is the document templates and rules transaction, and this is where the payer tells the provider, for this patient and this requirement, what do we need to see? What are the clinical requirements and what do you need to submit? And then the last transaction is the prior authorization support, or PAS transaction. And that's the transaction where the provider is submitting the prior authorization. There's a case number attached. There's status going back and forth. So in order to accomplish this, the provider is going to need to support these transactions either within their electronic medical record system or in an interface often called a Smart on Fire application. And this is an area where there's lots of discussion within the marketplace because essentially the ultimate scenario is where the electronic medical record system directly supports these standards. The challenge is that means that those standards need to be well defined between the payer and the provider, and there's still a little bit of work being done to really clarify and fine-tune the ways these standards are going to work. An alternative is for the provider to utilize a Smart on Fire application. Usually these Smart on Fire applications are closely aligned or provided by the payer and their system. The challenge in those scenarios is that the Smart on Fire application, much like an application you would load on your iPhone from the App Store, needs to be approved and verified by the IT department at the provider, and of course, needs to be tuned to each payer, which means that the provider might need to load multiple different Smart on Fire applications to support different payers. So this is just one of the challenges that's being discussed and worked through as this standard evolves. Ultimately, Itiliti Health believes that the best solution is for the EMR systems to directly support the prior authorization standards and Smart on Fire applications to be only used in the rarest of cases. The other key requirement for this interface is that the health insurance plan, the payer, be able to support these transactions through technology systems. One of the challenges with that today is that most payers have their rules or their is-auth required answers buried in a prior auth list or a spreadsheet on their public website. And that's not going to be a good way for technology systems to talk back and forth. It's not really going to support this API. The second challenge is that most payers keep their medical policies and clinical guidelines in PDF documents. Again, not a very efficient way to work with an API system that's talking with technology on the provider side. So what's going to be needed for the health plan is that they implement a comprehensive rules database application that can answer this coverage requirements discovery or is-auth required question accurately and efficiently. So it needs to be a technology system that can absorb those prior authorization lists and go well beyond those. So for instance, most prior authorization lists don't have an indicator for each CPT code of when that CPT code is started to be required as a prior auth requirement, or when that CPT code is no longer going to be required to require a prior authorization. So there's dates, other carve-outs for each commercial organization as commercial organizations support these rules. As you can imagine, a health plan has different policies and different rules for some of their commercial clients. These tools in this comprehensive rules database need to be able to support all of those carve-outs and differentiations. The next component that's needed on the payer side is a medical policy database application. As I mentioned, PDF is not a very efficient way for this system to talk to the provider. So we need to break those policies down into discrete items. So each row or each line of clinical criteria needs to be in a database and explicitly identified with its own database elements, so that when those rules are sent over to the provider's technology system can attempt to identify the information that it needs for each row of information in the medical policy. So that means that those PDFs need to change format. And then ultimately, once the prior authorization is submitted, the health plan needs technology that's going to help decide if a prior authorization should be approved or not. Sometimes those decision applications will sit in front of the system and look very closely at structured data that's been submitted within the prior auth submission. In other cases, those decision applications will have to absorb multiple pages, sometimes of digital images rather than structured PDFs, and essentially OCR those documents and compare them to rules and help the health plan find out whether or not the member's medical record shows evidence of compliance with the clinical criteria. So these are the three core elements on the payer side that are needed, that are typically not in place today. And of course, that's going to get us to this beautiful future where electronic medical record systems and payers technology are going to talk seamlessly, and everything's going to be real-time decisions, and everybody's going to live happily ever after. As we know, this is a challenge because there's going to be a transition period. For a long time now, we're going to see providers that still want to use the fax and telephone. We're still going to have websites and provider portals that providers want to utilize. And some providers, of course, will implement EMR solutions, but this is all going to take time as a transition. So at this point, I'm going to take a step back and talk a little bit about what are some of the key questions that the payer needs to be thinking about as they design their solution. So one of those questions would be, do you have the influence with your providers to convince them to load your Smart on Fire app in their EMR? And how many of your providers do you have that level of influence with? So that's going to help you determine whether or not a Smart on Fire app solution is going to be an appropriate approach for you, or if you need to be looking at native EMR support and a solution that supports that transition. Another key question is, where are your prior authorization rules stored? What is your source of truth for those rules? In most health plans, before we implement, we find those rules buried again in spreadsheets, in various systems, maybe deep in the contracts that are written between the payer and a commercial client. So it's really important to identify, how are you going to build a source of truth for your organization? Another question is, how are your medical policies and clinical guidelines going to be converted into discrete criteria? Again, as an example, most clinical guidelines have multiple questions in kind of a Boolean format that say, for instance, if the patient meets this criteria, then the patient must meet this criteria, or if not, they must meet these two criteria. So each of those elements need to be in their own database row, and in order for these systems to work. Some organizations are taking the approach of saying that those PDFs are still going to be the primary method of communication from the payer around their rules, and that the provider or some other AI tool is going to ingest those PDF documents and convert them into discrete data elements. Other organizations are looking at reformatting their medical policies into a more discrete format in the creation of those guidelines. And at that point, they're not having to rely on AI to do this conversion on an ongoing basis. Another question that you need to ask is, how long do you think it will take your providers, partners, EMR systems to support this new API? And the reason this question is important is that if you think your provider partners are all going to jump to this new standard quickly, maybe you don't have to worry about your provider portal being as efficient as your new EMR direct API connectivity. If you think it's going to take a long time, then you want to make sure that whatever solutions you select are kind of backward compatible with the old way of doing things with provider portals and even being able to support your call center in answering questions from providers. So with that, I'm going to convert over and move over to a little bit about how Itiliti Health recommends that you address these areas. Just a very quick note about Itiliti Health. We actually started inside Blue Cross Blue Shield of Minnesota. We built a platform that can absorb all the rules and medical policies of the health plan. It's been deployed at multiple health plans and has gotten some great honors from various consulting organizations, and has also performed a large volume of prior auth checks throughout the last couple of years. So this system is in place, scaled across multiple lines of business, and works very well for our customers. So now to describe the specific products from Itiliti Health and how they fit into each category. So our product called PA Checkpoint answers the is auth required question. It's a database that's configured by the health plan, and the provider accesses it to answer this is auth required question. The medical policy management tool from Itiliti Health helps to deconstruct those medical policies from a PDF into a more structured format, while at the same time aiding the health plan in managing content changes to those medical policies and publishing them to their website. And then PA Complete Clinical Assistant has multiple modules that sit behind on the payer side, so that when a prior authorization is submitted, the payer has tools to quickly analyze and determine whether or not a prior auth should be approved. How that translates into the FHIR standards, PA Checkpoint is that CRD is auth required database that knows all of your rules and can answer this CRD question. The Itiliti Health Policy Management product is the product that deconstructs your policies and can provide that transactional support for documents, templates, and rules. And Clinical Assistant is the tool that can help the health plan make decisions and automate the prior auth decision process. Just a little bit more about each of these solutions. PA Checkpoint is a product that you access, that providers and payers can access through the payer website, through the payer's provider portal. The EMR can be integrated to this solution, and there's an administrative portal, because this is a SaaS-based product that is essentially a tool that we provide as a database and a very easy to use front end that allows the health plan to manage their rules in this system. This PA Checkpoint product becomes your source of truth, replacing your spreadsheets and prior auth list and putting them into a much more efficient, structured format. What that means on the provider portal or the public website of the health plan, on the left side of the screen, obviously I don't expect you to read this, but what you see is the prior auth lookup tool as it sits inside of the health plan's public website or provider tool or provider portal. The provider enters their provider ID, group number of the patient, date of service, and procedure codes, and they get a very clear answer back, yes or no prior auth is required, what medical policy applies, and what's the next step in the process. So that's what you see on the right side of the screen. In addition, just this January, about the same day that CMS finalized their compliance or their new rule, Itiliti Health and Epic demonstrated the CRD compatibility directly with Epic between PA Checkpoint and Epic, which essentially means that within the Epic system, providers can perform their normal roles. Doctors write orders for procedures. The Epic system automatically asks PA Checkpoint if a prior authorization is required, and PA Checkpoint's answer is displayed inside of Epic for the referral coordinator as they perform their functions. So this is a real monumental event for us in the ability to show that you don't need a Smart on Fire app to perform these types of CMS compliant transactions. PA Checkpoint as a front-end screening tool before prior authorizations are submitted has been proven to be pretty efficient and save a tremendous amount of money for our health plan clients. One health plan found that they reduced call center traffic to the provider call line by over 20%. In this case, about 150,000 phone calls per year. The call center response time was shortened because the call center uses the same tool and also reduced disputes. A smaller Blue Cross Blue Shield health plan identified that they saved about $3 million in annual savings. And they identified that in the first 4 months because their call center was giving sometimes the wrong answer to the question of is an auth required. And in those cases, they were required to pay those claims. And then lastly, the big impact is that 30% of prior authorization submissions were eliminated. And that's because now the provider has a clear sense of whether or not a prior auth is required. They can go ahead and perform services without the delay of a prior auth, and everybody wins if that information is accurate and the provider can move forward quickly. Another product that I outlined in that description was policy management module. Again, essentially, policy management module is available through all the same channels that PA Checkpoint is. It converts policy documents from a PDF structure into a structured format where the health plan can then utilize this tool as they make changes to policies and can review and verify that the conversion from a PDF to a structured format is correct the first time. And then from then on, they edit their policies in the policy management tool, which adds a tremendous amount of efficiency to the content management and the approval process around prior auth policy changes. And then lastly, Clinical Assistant, as I explained, is a product that helps the health plan make decisions around the prior authorization itself, whether or not it should be approved. It has the ability to display the medical policy and the medical record side by side, assists in finding a match for each medical policy criteria, and documents that match. And this really helps to ensure that health plans efficiently and effectively determine whether or not a prior auth should be approved. The Itiliti Health product suite includes a number of items that I didn't talk about, but ultimately what we've built is a foundation that rests on your medical policies and prior authorization rules and automates and streamlines the process from helping your providers know where to submit a prior auth, routing prior auths to the right destination, all the way through automated approvals. Each of these products are delivered as discrete modules. So we have found some companies that have only used one module of our products, and they use our APIs to easily build those modules inside of their solutions that they've constructed. So what does this mean as you look forward? Well, essentially, as I mentioned, PA Checkpoint helps to answer that question of is auth required, and it fits into whichever channels your providers have the capability to use or wish to use. So if they call, your call center can use PA Checkpoint to answer questions. If they use the web, providers can self-service to answer the question, is a prior auth required? And of course, this product works really well in the FHIR API world. Similarly, policy management works with all of those same mechanisms to help ensure that your providers know exactly what's required for a prior auth submission. And then Clinical Assistant works in conjunction with your or care management tool to help you make better and faster decisions. So again, that's how PA Checkpoint, Policy Management, and Clinical Assistant fit into the new PA prior auth API requirements. So one of the questions we get most often from health plans is, where do we start? How do we get this going? And we know this is a long timetable, but there's a lot of work to do. So Itiliti Health has developed a path forward, or a phased approach that helps you really have a glide path to get to this full electronic health record automation. The first step is to implement the Itiliti Health PA Checkpoint, which really is an enhanced CRD. And it helps you to support that is auth required question, whether or not the provider is using a portal or planning to use the CRD capability within new EMR system integrations. The next step is to convert your policies into a more structured database. And this has some significant impacts even for those providers that are using the portal, because this allows your system to come back and not only tell them whether or not a prior auth is required and which policy applies, but to explicitly tell them which documents to submit and which submission form to use. The next step in the process is to integrate this capability with the new EHR submission capability that comes from the prior auth FHIR rules. In other words, these medical policies that have the ability to know what are the required documents and what's the submission form needed can deliver that same information over to the electronic medical record so that the EMR can display the required documents in the EMR and allow the administrator to attach those, or in some cases, EMR will automatically attach those documents. Similarly, the submission form for a prior auth will be converted into CQL, so the administrator at the provider can see that provider form, that payer form inside the EMR. Some EMR systems will be able to automatically fill out that submission form, and in other cases, the administrator can fill that out. And then lastly, the last phase of this process is where the very detailed clinical questionnaires that would be within your medical policies are converted into this new format. And at that point, the EMR hopefully will be able to automatically answer all of those clinical questions. So again, to talk about this in terms of a glide path, we can start by helping you get fewer misrepresented policies, reduce your submission volume and telephone calls. Second, we can give your providers rapid access to knowing which specific prior auth requirements are needed so that they increase the quality of their submissions. The next step is decreasing the amount of sites that providers have to log into by allowing them to stay inside their electronic medical record system for submission. And the last step is a true automation of the answering of questions and the quick decision on the payer side. So that's the glide path that Itiliti Health recommends. And what's exciting is this enhanced CRD is something you can implement in 3 months. You can do that today, and this will be compliant with the new standards and support whatever tools and approach you take for the other phases of the process. So with that, I'd like to close out my comments by thanking you for the opportunity to present today. Really excited to have the opportunity to present in conjunction with Deloitte today, and we'd be happy to supply you with a demonstration of our capabilities and a deeper conversation if you're interested. So we'll look forward to conversations with you all in the future. Thank you.
Thank you so much for joining us today for this enlightening presentation. If you would like to get in touch with any of our panelists, their information's on the screen. It's also available for download to the right near the comment box. If you have questions, please feel free to reach out. We'll also be following up with a download of the slides that were shared on this presentation and the contact information that you see in front of you now. Have a wonderful rest of your day.